Hello, my name is Erica Mandell. I'm a neonatologist and the co-director of the Transitional Ventilation Support Team in the NICU here at Children's Hospital, Colorado. I have a specific clinical and basic science research interest in antenatal and postnatal risk factors that contribute to the development of severe bronchopulmonary dysplasia. One of the major risk factors for developing severe bronchopulmonary dysplasia is the need for prolonged mechanical ventilation. There have been substantial research efforts and strategies developed to help extremely preterm infants successfully extubate within the first few weeks of life after they recover from acute respiratory distress syndrome, RDS. These interventions have been largely successful, as the vast majority of extremely preterm infants do in fact successfully extubate before a month of age and have had milder respiratory courses. However, some preterm infants develop particularly severe chronic lung disease with prolonged needs for high levels of respiratory support throughout their NICU course and post-discharge. Infants with evolving severe chronic lung disease are very complex, and their pulmonary mechanics change dramatically over time as they recover from acute RDS within their first week of life to established BPD, a diagnosis they receive once they reach 36 weeks post-menstrual age. The pulmonary mechanics of an infant with RDS, as depicted in the chest X-ray on the left side of the screen, is characterized by stiff lungs, meaning they are hard to open and easy to collapse due to decreased lung compliance and high elastance. Without an anatomical obstruction, the airway resistance is usually normal in these infants, and hence the time constant is usually short, which means that the alveoli of these infants are fast to inflate and deflate, and the aeration, for the most part, is homogeneous. The lung mechanics of an infant with established BPD, as depicted in the chest X-ray on the far right of the screen, is harder to find the optimal ventilation, as these lungs are heterogeneous, injury with areas of atelectasis, hyperinflation, and cystic changes. Therefore, the lung compliance may be high in some areas, but low in others, and the airway resistance is often high due to hyperplasia of the airway smooth muscles, air trapping, airway malacia, or secretions. And while we understand the pulmonary mechanics at both ends of the disease spectrum, many questions remain regarding the timing of changes in pulmonary mechanics in infants who continue to require mechanical ventilation after the resolution of RDS, but have not yet fully established severe disease. As depicted in the middle chest X-ray is the same infant, about 6 to 7 weeks of life, who already is demonstrating varying areas of lung injury with areas of atelectasis, hyperinflation, and cystic changes. Some of the hardest questions many of us as neonatologists and pulmonologists caring for infants in the transition phase of lung disease is when and how to transition ventilator settings to match evolving lung disease, and if all infants requiring ventilation past the few weeks of life are going to develop severe BPD and need prolonged ventilator support. Early ventilation strategies used to prevent chronic lung disease use low tidal volumes, short inspiratory times, and higher respiratory rates, which works very well for RDS physiology. We have found that infants with severe established BPD are not well managed with this acute ventilation strategy. With the development of the ventilator care program over a decade ago, we have found that chronic respiratory support strategies require higher tidal volumes, longer inspiratory times, and slower rates than those used with early lung protective strategies. At some point during the respiratory course of premature infants with evolving BPD, lung structure and function become sufficiently abnormal, and the ventilation mode of choice and settings must adapt to the patient's changing physiology. These ventilation changes include increasing tidal volume, either by increasing the set tidal volume or increasing the peak inflation pressure, lengthening the inspiratory time and slowing the rate to prevent gas trapping with the evolution of increasing airways resistance. There is not a specific postnatal gestational age that is recommended for these changes to take place. Some indicators that infants need to transition away from acute ventilation strategies include sustained respiratory distress with retractions, recurrent cyanotic or bradycardic episodes, intolerance of respiratory and physical therapies or handling, poor growth, and the apparent use of or need for repeated steroid courses without sustained benefit. The timing of onset of these episodes in ventilated infants is variable, although these often develop within the first month of life. Since lung injury plays an important role in the development of BPD, much of research efforts have focused on finding proper respiratory support strategies that avoid or minimize lung injury. However, we need to keep in our minds that the ultimate goal of prolonged respiratory support is to promote healthy life, and avoiding lung injury is only one aspect to helping us reach this goal. It is important to remember we are trying to support a whole person, not just a pair of lungs, as the lung health will affect the well-being of other organ systems. Chronic respiratory insufficiency in infants with evolving or established BPD also create challenges for the infant to grow properly. Therefore, the goal of respiratory support for a preterm infant transitioning from RDS to BPD should not be aimed at solely keeping the PCO2 and SpO2 in acceptable ranges, but rather providing adequate but not too much support that will support proper growth and injury repair while avoiding or minimizing further lung injury. Maintaining an open lung is an important protective ventilation concept to prevent the evolution of RDS into BPD. The open lung strategy helps to distribute the tidal volume during traditional mechanical ventilation evenly throughout the lungs and to avoid the shear stress from repeated collapse and reopening of the alveoli. In mechanical ventilation, the open lung is mainly achieved through applying adequate PEEP, and while appropriate PEEP levels may result in clinical benefit, both inappropriately low or high levels may cause harm. An appropriate PEEP level may be best achieved by using oxygen-guided lung recruitment maneuvers with gradual PEEP level titration that allows for individualizing PEEP needs for each infant. Changes in respiratory rate, tidal volume, inspiratory and expiratory times, and pressure support are highly interdependent and cannot be made in isolation. For example, increasing the inspiratory time and tidal volume to allow for better gas distribution into distal lung units without slowing the ventilator rate, often less than 18 to 20 breaths per minute, will prohibit sufficient gas emptying given the developing obstructive airways disease and lead to hyperinflation. Faster rates with increased tidal volume and prolonged inspiratory times will worsen gas trapping, leading to patient ventilator asynchrony and worsening ventilation. Monitoring flow waveforms can aid in determining whether expiratory flow has been completed before the next breath is delivered. These infants have complex and prolonged clinical courses with multiple morbidities, and often with poor continuity of care, leading to a wide variation in the development of severe BPD among NICUs. With high provider turnover, these infants can be exposed to vastly different ventilation strategies depending on the provider's experience with ventilator management of evolving chronic lung disease. Frequent strategy changes or a hybrid of acute and chronic strategies usually leads to poor outcomes. High staff turnover and poor communication between providers, subspecialists, nursing staff, and families during prolonged hospitalization also can lead to inconsistent care and adverse outcomes. Families have identified that communication and consistency from the medical team are paramount to establishing trust and decreasing anxiety with frequent change of providers during their prolonged hospitalization. Providers have identified that collaboration and consistency of treatment strategies become difficult to achieve with families of infants with prolonged mechanical ventilation needs. In order to support infants at the highest risk of developing severe BPD and their families, we have a continuum of well-established and structured teams to support extremely preterm infants at various stages in their respiratory course. Dr. Laura Mars leads the extreme preterm team for infants born at 22 to 23 weeks to provide comprehensive support in addition to physiologic-based ventilation strategies for preventing severe BPD in this very high-risk population. Dr. Huyen oversees the small baby team for infants born less than 32 weeks, as well as the co-director for the ventilator care program, which provides highly effective ventilator strategy to support infants with established severe BPD who need long-term ventilation. but are able to grow and develop and eventually be discharged home with their families. In attempts to address many of the respiratory morbidities related to prolonged and complicated hospitalizations of infants with evolving severe chronic lung disease, the formation of a transitional ventilation NICU team was formed in 2020. We formed the Sprouts team as an extension of the ventilator care program to provide a consistent and physiologic-based respiratory practice approach for extremely preterm infants earlier in their NICU course to improve respiratory and neurodevelopmental outcomes. Through our consistent and collaborative approach with providers, subspecialists, nursing staff, and families during these prolonged hospitalizations, we work to improve and sustain good communication and working relationships with the families of infants at risk of developing severe BPD. The population of infants cared for by the Sprouts team includes any infant born less than 29 weeks gestational age with continued significant positive pressure needs at 4 to 6 weeks of age. Significant positive pressure needs include any invasive mechanical ventilator support, or infants at 32 weeks corrected gestational age with non-invasive bi-level support, including NAVA ventilation, and any infant classified with severe BPD at 36 weeks corrected age. The goals of Multidisciplinary Sprouts team are to establish medical care consistency among providers with respect to ventilation management and medication management. We also strive to improve communication and collaboration between providers and families with the ultimate goal to improve growth and development for infants with evolving severe BPD. Our team includes primary neonatal attendings, nurse practitioners, nurses, respiratory therapists, and a pharmacist. We work in close collaboration with our pediatric pulmonology colleagues and the ventilator care program director, Dr. Chris Baker. Our Sprouts multidisciplinary team meets twice a week, once to discuss patient clinical updates and individual management strategies, and once to discuss and move forward research projects. Our unique physician team is comprised of basic scientists, clinical researchers, and QI experts. Our basic scientists investigate developmental lung physiology and respiratory mechanics, molecular understandings of specific antenatal and postnatal risk factors that contribute to the development of severe BPD, as well as potential therapeutics to modify severe clinical courses. Our clinical researchers translate this basic science knowledge into bedside clinical interventions for treating severe BPD. Our perinatal QI experts implement evidence-based interventions in a rigorous way, measuring clinical processes and outcomes, as well as the experiences of the families during prolonged NICU hospitalizations. For our educational piece, we have created a specific chronic ventilation elective for pediatric residents and subspecialized fellows as an opportunity to learn in-depth transitional and chronic ventilation management. Our multidisciplinary team is also available for virtual educational outreach and patient consults. We are happy to discuss management questions and patient referrals as needed. Please reach out to us at the Sprouts email with any questions and opportunities to provide support for infants with prolonged ventilation requirements.